Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Otsuka America Pharmaceutical, Inc.
Hello, everyone. I'm Brad Roven. I'm a professor of nephrology and the director of the Division of Nephrology at The Ohio State University Wexner Medical Center in Columbus, Ohio. Welcome to this program entitled Emerging IgA Nephropathy Advances, Digging Deep into the B-Cell Pathway. I'm delighted today to be joined by my colleague and actually one of my former fellows, Shikha Wadhwani, who is now associate professor at the University of Texas Medical Branch in Galveston, Texas. Welcome, Shikha.
Thanks, Brad. I'm so happy to be here.
So let's get started. And Shikha, why don't you give us a brief overview of IgA nephropathy, pathogenesis, and the prevalence and significance of the disease?
Sure. So, as we all know, IgA nephropathy is a rare kidney disease. The incidence in the United States is around 2.5 per 100,000 adults, and that may be a little bit of an underestimate just based on, biopsy data. Now, IgA nephropathy is more prevalent in Asia than in other regions of the world, and it actually accounts for up to 30% of kidney biopsies in Asia. But worldwide, it's the most common primary glomerular disease, and it can present with gross hematuria, it can present with asymptomatic microscopic hematuria, and variable degrees of proteinuria. So it's quite heterogeneous in its clinical presentation. But most patients, at least here in the United States, do have some evidence of CKD at the time of presentation. And traditionally, it was felt that something like 30 to 50% of patients would progress to end stage kidney disease if they were diagnosed with IgA nephropathy. And that, of course, depends on the demographic you look at and the length of follow up. But more recent data from the UK Radar Registry, as well as other large cohort studies around the world, are showing that patients with even lower grades of proteinuria than we would expect may in fact progress to end stage kidney disease sometime during their lifetime. So, in short, this is a rare kidney disease, but it really does account for a significant disease burden in nephrology. Now, in terms of the pathogenesis of IgA nephropathy, there have been a lot of advances in our understanding of how IgA nephropathy develops. And what's really sort of understood at this time is there is likely a four-hit hypothesis to the pathogenesis. So, in susceptible individuals, and that could be related to genetic factors, environmental factors, something triggers increased levels of circulating galactose deficient IgA1. And that galactose deficient IgA1 is thought to likely come from the gut predominantly. That can then lead to the production of anti-Gd-IgA1 antibodies, which can be either IgA or IgG antibodies. Those combine with the galactose deficient IgA and form immune complexes. And those immune complexes are the problem. So those immune complexes then travel to the kidney, specifically to the glomerular mesangium, where they can cause local immune activation, complement activation, and various, cytokine, chemokine release, and ultimately lead to glomerulosclerosis, interstitial fibrosis, and tubular atrophy, and lead to that kidney damage that can ultimately result in end stage kidney disease that we discussed. So that's our current understanding of IgA nephropathy. And I'd love to know, Brad, if you have a patient with IgA nephropathy that you wanted to share their case with us.
Well, it so happens I do. And it'll be fun to talk about this patient with you. The patient is a 35-year-old who was found to have some blood and protein in their urine during a routine exam for work insurance. Uh, the patient was referred to a nephrologist, and he notes that when he was young and in school, he saw some blood in his urine a couple of times when he had the flu. Nobody really thought much about it, and he wasn't evaluated at the time. So, about a year ago, he was found by his primary care physician to have hypertension, and he was started on a diuretic, and his blood pressure has generally been in the 120 systolic range since then. He's never had any other systemic symptoms, including rashes. When he went to see the nephrologist, the exam was unremarkable, but his urinalysis showed a specific gravity of 1.020. He had moderate blood and 3 plus protein on dipstick. A microscopic exam at the time showed a lot of red blood cells, too many to count, and there were acanthocytes and at least one red cell cast. Laboratory data were significant after that visit for a serum creatinine of 1.6, an estimated GFR of 72, and a 24-hour proteinuria of 2 gram per day. The nephrologist started the patient on an angiotensin receptor blocker and advised the patient to have a kidney biopsy. That was done about 2 weeks later, and the biopsy showed IgA nephropathy, and the MEST C score was really quite interesting. It was an M1, so he had mesangial proliferation. It was an E1 lesion, but he also had an S1 lesion and a T1 lesion in terms of his interstitial fibrosis and his glomerulosclerosis. He had no crescents on the biopsy. So, in summary, this patient has IgA nephropathy. It appears to be active, and I'm going to suggest that this is long-standing, probably since childhood, as evidenced by some of those episodes of infection-associated hematuria. And the patient has a modest degree of kidney injury. So, Shika, how would you approach this case if this was your patient?
Yeah, so unfortunately, this is more of a common presentation than we would like in our glomerular disease clinics. And I agree with you. I think that this patient has evidence of active disease, but also has features of chronicity despite being quite young. And I think that is one of the concerns with these patients with hematuria, multiple episodes throughout their lifetime. As you mentioned, we may not know what's really happening at the tissue level. So I think it being 2024 now, we have more tools in our armamentarium than we had, 5, 10 years ago. And I would really want to manage his IgAN with a multi-targeted approach. So first and foremost, we want to turn off his immunologic disease and, if possible, reduce or even try to stop the production of the pathogenic IgA1. At the same time, he already, despite being young, has evidence of modest nephron loss, and he's at risk of further disease progression. So we need to simultaneously treat the kidney injury aspect of his IgAN as well. Is that along the lines of what you were thinking?
Exactly. I couldn't have said it better. I think that we have to target his immunologic disease, and the medication that we have now that's approved by the FDA is targeted release budesonide. And as you noted earlier, we do think that the galactose deficient IgA, which is sort of really the antigen in this immune complex process, comes from mucosal surfaces. And of course, the gut has the largest mucosal surface and has quite a bit of its own intrinsic immune system in the Peyer's patches. And so I would like to treat this patient to block HIT1, block the production of galactose deficient IgA1 using what we have available that's been approved, targeted release budesonide. And then we have the other issue that you raised, which is this is a young person that already has impaired kidney function. And his creatinine and GFR are clearly abnormal for a 30-year-old. And so we can add RAS inhibition, which we always sort of do and have done in IgA nephropathy. And it's really important to point out, frankly, that all of the clinical trials that have been done, and we'll discuss in this little seminar, have been done on a background of RAS inhibition. But today, we also have the ability to enhance RAS inhibition by using a RAS inhibitor plus endothelin antagonist. And that has also been shown and approved by the FDA to reduce proteinuria in patients with IgA nephropathy and help preserve GFR in the long term. Now, of course, one of the more popular drugs that we have these days are SGLT2 inhibitors to reduce progression of chronic kidney disease. And this is also a possibility to add. I'm not sure exactly that I would need to add that right at this point in the patient, but certainly something to consider for the future. But I certainly want to get the immunologic disease under control. So, what about you? Do you have an example of a good case?
Actually, I do. I have a patient who is a 24-year-old woman. She has a history of an eating disorder, and she was referred to me for microscopic hematuria and proteinuria. So we spoke, and she has no family history of kidney disease, no family members with microscopic hematuria. When we took a look at her urine, she had 50 to 100 RBCs per high power field. And being a woman, we made sure that this was several weeks after her menses. And then we got a spot urine protein to creatinine ratio, which was 2.6 grams per gram. And we verified this with a 24-hour urine collection. At the time she saw me, her serum creatinine was zero point 0.7 milligram per deciliter. And so her eGFR was predicted to be greater than 90 ml per minute. Her exam, she didn't have any pertinent findings other than her blood pressure was on the lower side at 92 over 60, not surprising for a 24-year-old young woman. So, we spoke about a kidney biopsy and we obtained the biopsy within a few weeks. A bit to my surprise, she had a very inflamed kidney. She had 6 crescents and a sample of about 30 glomeruli, and her Oxford classification score for the IgA nephropathy was M1, E1, S0, T0, and then C1. So, in short, I have this young woman. She has hematuria, proteinuria in the setting of preserved kidney function, low blood pressure, but a very active biopsy. So I'd be curious, how would you approach this patient, and would it be similar to or different from, your own patient that you mentioned?
This is a really interesting case, Shika. I think obviously, the main difference between these cases is that your patient has a lot more acute inflammation. And I'm defining inflammation, if you'll give me that latitude, as endocapillary hypercellularity and crescents. And we can debate about whether the mesangial proliferation is inflammatory or not. I'm sure some white blood cells can sneak into the mesangium. And she has no chronic damage at this point. And this is reflected in her GFR, and it's reflected in her S0 and T0 scores on the MEST evaluation. So I still want to treat this patient to target hit one. I want to get the galactose deficient IgA to come down and to eliminate that as a possibility to form the immune complexes. I would still probably want to have RAS inhibition on board, but now I'm a little bit worried because you told me that she is like so many young folks. She has a very low blood pressure and she may not be able to tolerate RAS inhibition. Um, and this really gets to my next point. Um, Almost all of the nephron sparing medications that we use, so medications to prevent progression of kidney disease, have some hemodynamic effect. Certainly, ACE inhibitors, ARBs, and now combinations of ARB plus endothelin antagonist. And so this might be a case where, we have caught the patient early. Yes, they have a chronic kidney disease for sure, but they don't have damage that we can see. So it might not be important to pile on um, antiprogressant drugs right now. Now, certainly that would be something to consider for the future because at the end of all this, they're likely to have had some chronic damage to the kidney because it will take some time to resolve. But the other thing that really bothers me about your patient is that they really are showing a lot of inflammation. And I want to attenuate the inflammation as quickly as possible. Um, the level of inflammation is something that's likely over time to really give more damage to the glomeruli and eventually the tubular interstitium. I think the two drugs that we can think about in this setting to target inflammation are systemic glucocorticoids. And we do know from some of the larger trials that systemic glucocorticoid administration, prednisolone in particular, in the testing trial, did suggest that we could have a decline in proteinuria and sort of a stabilization of GFR, at least as for some period of time. And if you'll recall from those studies, that after a while we saw the proteinuria start to come back up and the GFR start to decline again. But at least for a brief point, this could be useful in controlling inflammation. Now, importantly, I do have to say I am sort of basing what I say on how I think these drugs should work, right? Glucocorticoids are very anti-inflammatory, as you know, and it's important to think about how they might work, but that hasn't been proven in IgA. The other drug that is now available that's been approved is in the category of a complement inhibitor. And of course, I think about complement inhibitors all the time when I look at my lupus patients. And I very much believe that these are anti inflammatory medications as well. And so I would consider adding a complement inhibitor to this patient and treating the patient with targeted release budesonide, which are the tools I currently have. Does that sort of resonate with you?
Yeah, absolutely. And I think that, as you mentioned, you know, we're hopefully catching her early on. We have a window of opportunity to really address, I think, the pathogenesis of the disease. And, I think that, as you know, IgA nephropathy is really in an exciting phase right now. We have the targeted release budesonide to target HIT1. That's really what we have right now for early in the pathogenesis of this disease. We have several agents that are targeting HIT4, but I think this is likely to change soon. And I'd be curious, about what class of drugs looks promising to you in terms of tackling HIT1 and maybe even HIT2 in the IgAN pathway, recognizing that you have a particular interest from the lupus world, and I think this is very much in your wheelhouse.
Well, um, that's all true. I think it's very clear. And in fact, many years ago, we actually looked at rituximab for IgA nephropathy, but it turned out we never saw a sustained effect on proteinuria or GFR with rituximab. And although we did confirm that B cells were depleted, there was no actual fall in galactose deficient IgA1 or IgG antibodies to galactose deficient IgA1. But other investigators started looking at, instead of B cell depletion, by modulation of the B cell by inhibiting growth factors, B cell growth factors and survival factors, in particular BAFF, which is also called BLIS, or APRIL. And it's important to get a little background on this. The consequences of BAFF inhibition are decreased B cell maturation, and of course, then fewer mature B cells circulating, decreased overall levels of immunoglobulin, and decreased T cell dependent antibody production. A little bit of contrast, The consequences of APRIL inhibition are selective IgA reduction compared to IgG. So, particular interest to us here. Intact B cell maturation, as it turns out, intact responses to vaccination, but reduced plasmablast and plasma cell survival, which of course are the cells that produce antibodies. Now, what has been shown by several investigators is that in preclinical models of IgA nephropathy, APRIL inhibition could actually decrease IgG IgA immune complexes and immune deposits in the kidney. Interestingly, in mice that were made to overexpress BAFF, they actually developed a glomerulopathy that was very similar in appearance to IgA nephropathy. Supporting this idea, this animal work in humans, is the fact that if you measure BAFF and APRIL levels in patients with active IgA nephropathy, they're actually elevated. And so this actually led to several trials examining APRIL or the combination, which sort of makes sense because each of these growth factors does a little bit different thing for treating the patients. BAFF and APRIL antagonists in the treatment of IgAN patients. Shika, why don't we go over some of these exciting data?
Absolutely. So I think we'll start with sibeprenlimab, which I'm henceforth going to refer to as Sibi. So, Zibi is a humanized IgG2 monoclonal antibody that binds to and neutralizes APRIL. So, exactly along the lines of what you're saying. And Zibi's been tested in a phase 2 trial called the Envision trial. This was a multi center, double blind, randomized, placebo controlled parallel trial in which patients were randomized in a 1 to 1 to 1 to 1 ratio to either placebo or 3 ascending doses of Sibi, either 2, 4, or 8 milligrams IV. So, the primary endpoint of this phase 2 trial was change from baseline in the log transformed 24-hour urine protein creatinine ratio at month 12. And then these patients were followed up for another 4 months after that. So the inclusion criteria are what you would expect of a typical IgA trial. These patients had over a gram of proteinuria. They were adult patients. GFR was greater than 30, and they were maxed, as you mentioned. Patients are in all of our clinical trials on RAS inhibition. The important thing to note is no immunosuppressive therapy or steroids was allowed in the 16 weeks prior to screening. So, if you look at the type of patients they ended up enrolling, one thing to kind of mention is this was a predominantly Asian population. About a quarter of patients were white, but the vast majority were Asian. And these patients were fairly recently diagnosed in terms of their IgAN. We have some trials where patients have had their diagnosis for several years, but this was a little bit more of a naive population, perhaps. The mean urine protein creatinine ratio was in the 1.5 gram per gram range or so, give or take. And the eGFR at entry into the trial was in that mid 50 to mid 60 range, again, showing that these patients already had some degree of chronic kidney disease. So if we look at, what did that primary outcome show? It was looking again at that 24-hour UPCR at month 12, and they saw significant reductions in UPCR with Sibi in somewhat of a dose-dependent fashion compared to placebo. And what was important was that reduction in proteinuria was sustained even past the 12-month treatment period for the 4 and 8 milligram per kilogram groups. And then in addition, there were also reductions in Gd-IgA1 and APRIL levels. Kind of talking to what you mentioned, it sets this apart from the rituximab data that you discussed earlier. Now, of course, we are very excited about proteinuria data as well as biomarker data, but what we really care about is GFR. And eGFR at 12 months was a secondary endpoint. What you see is that all groups of SIBI had an attenuated decline in their eGFR compared to placebo, again, at the end of that 12-month period. Um, this is phase 2 data, but I think it's very reassuring and exciting as we look forward to the phase 3. What I really was excited about, in addition to this, was an exploratory analysis of the Envision data, looking specifically at the circulating immune complexes that were measured. And this was presented at the ASN 2024 Kidney Week. And what I thought was really exciting is that they were able to show reductions in circulating immune complexes in all of the SIBI treated patients compared to placebo. But not only that, one thing that is important to know about the study design for Envision is that patients were treated for 9 months and then they were off treatment for 4 months. And so, what you can see here is that not only is there reduction in circulating immune complex levels through the 12 months, but then once the drug is stopped, you can see that rebound effect, which maybe points to the fact that when we're thinking about these kinds of therapies, we really need longer duration. And if these drugs prove to be safe, maybe these really are going to be, cornerstone therapies for IgA nephropathy that can be continued long term, say how we continue medications in our transplant patients. So, speaking of safety, the incidence of adverse events was similar in the SIBI group and the placebo groups. And it's important to note there were very, very few serious adverse events. And again, those were similar between the groups that were treated with SIBI compared to the placebo group. So, at this point, things are looking very reassuring.
So that's great. And I'll just sort of say that what you've shown us is that SIBI could really target hit one, hit two, and even hit three, which is the deposition of immune complexes in the mesangium because it's decreasing immune complexes that are circulating.
Yeah.
So that remains to be proven. I want to introduce another medication that has been trialed, and these data are just a very quick summary, again presented at the ASN this past year in San Diego. And this is different than what you described with SIBI. This is povetacicept, which is a BAFF-APRIL combined inhibitor, and it contains an engineered TACI domain. So I'll just very quickly summarize. At week 48, the proteinuria fell by a mean of 66%, and the 24-hour urine protein to creatinine ratio in the target dose of 80 milligram per day declined from 1.3 gram per gram at baseline to zero point 0.5 gram per gram. EGFR slope, as you were talking about EGFR in the SIBI trial, was also quite good, and the decline in EGFR over the 48 months was just 1.1 mil per minute per 1.73 meters squared. Galactose deficient IgA1 fell by 69% in the patients at week 36. And importantly, total IgG only fell by 41% at week 48. So there is still some circulating IgG for protection and safety. But you have considerably more data on another BAFF-APRIL inhibitor.
Yeah, so atacicept, which is again a dual APRIL BAFF inhibitor, does have quite a bit of data. Atacicept is slightly different in that it's a fully humanized recombinant fusion protein, and what it does is it acts on the TACI receptor, which is expressed on mature B cells and plasma cells and can bind both APRIL and BAFF. So, the phase 2b Origin study is a multinational randomized placebo controlled trial of atacicept self administered at home via a 1 ml sub-Q injection. And the study design, again, similar to what we've seen with these biopsy proven IgAN patients who have high risk of disease progression and are on maximum RAS inhibition. In this study, SGLT2 inhibitor use was also allowed. And the primary endpoint was similar to the SIBI group, change in 24-hour UPCR. at week 24. So the baseline characteristics, again, similar to what you'd expect with the mean age around 40, there was good global representation. And so you kind of saw, patients that were white, Asian, and as expected in this type of cohort, again, there's some degree of CKD with GFRs in the 60 range and UPCR over 1.5. Again, suggesting that these patients are high risk of disease progression. So, in terms of the results, the primary endpoint, as I mentioned, was the 24-hour UPCR at 24 weeks. And what you can see is that the atacicept group had a significant proteinuria reduction compared to placebo. Now, there were two different doses tested, the 75 milligram and the 150 milligram, but the 150 milligram is ultimately what was chosen for the open label extension phase. And when you look at the you know, proteinuria reduction in patients going out all the way to 96 weeks, this is actually pretty unique because what you have now is you have the patients who were on the atacicept for the first, 36 weeks, who then got another 60 weeks of atacicept 150 milligrams, but then also the patients who were on placebo for the first 36 weeks, they also then switched over and received the 150 milligram atacicept dose. And what you see when you look at this data out to 96 weeks is continued proteinuria reduction as these patients stayed on therapy or were switched over from placebo to therapy, really over 50% reduction in the long term. And so, in addition to proteinuria, again, taking a look at GFR, when you look at the patients who were on atacicept, and this could be patients who started off, either on the 75 or 150 and continued, or this could be patients who started on placebo and then switched over to open label atacicept, you see that the mean change in eGFR is actually positive at most time points that were measured. And if you look at the annualized eGFR slope, it's only zero point 0.6 ml per minute per year decline all the way out to 96 weeks. And this is really the first study to show that degree of GFR preservation. And if you'll recall, when we, think about the radar data and the goals of really trying to get our GFR slope to 1 ml per minute per year, this type of data and, the fact that it's a very long-term data is really reassuring and really exciting, I think, for B-cell therapies and their potential. Um, and then, we've talked about hematuria as well as galactose deficient IgA1 levels, and you are seeing reductions in both of those parameters with atacicept, just as you did with the proteinuria reduction. So, in terms of safety, I think, again, a lot of reassuring data here. Um, you can take a look at either the double blind period or the open label period, but there were really very few treatment emergent adverse events, and there was no safety signal seen in the patients treated with this drug.
These are really some very exciting studies and data. And I just want to be clear to the listeners that we've only covered some of the drugs that are under investigation for IgA nephropathy. There are several other B cell modifying drugs that are being trialed, as well as drugs that target plasma cells. So, Shika, how would you apply these B cell drugs to patients we presented? Would you consider use?
Yeah, absolutely. I think that, the mechanism of action, the data that we've seen so far in terms of not just reducing proteinuria, but really preserving GFR long term. And as we discussed, um, profound reductions in Gd-IgA1 and even in some studies circulating immune complexes. I think this really builds a really nice picture for the potential for these therapies. And in terms of the patients that we discussed, I think B cell therapies could be used in either of these patients because they both have active disease, there's inflammation, but importantly, you know, these are patients who are at risk of progression, and we need to treat them early, and we need to try to really shut off the immunologic disease if possible. So I think in either case, a B cell therapy could be really beneficial.
Absolutely agree. Um, so, this is all the time we have for today. We really look forward. I think I can speak for you on the ongoing development and these phase 3 trials of all these B cell targeted therapies because they do hold a lot of promise for our patients with IgA nephropathy. I certainly hope, we hope that you found this informative and thank you for listening.
Yes, thank you, Brad, for this really great discussion. And, we thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
Thank you.